Good morning, Professor. Today my group and I are going to talk to you about fungal skin diseases. So fungal infections are caused by fungi that infect the skin. They are very common and contagious and are very curable with correct treatment. So how are they spread? Well, these microorganisms prefer conditions of hot and humidity. The mycosis will spread in areas with lots of people. So that would be basically swimming pools, showers, locker rooms, places where the hot and humid conditions are always present. In addition, the fungi are germs that are very opportunistic. So they attack the patients with very decreased defenses. This will be the elderly, patients with diabetes, or patients that are taking cancer drugs. Now we're going to talk to you a little about mycosis, superficial mycosis.
The tinea capitis. This is a dermatophytosis of the scalp. A dermatophytosis is a mycosis caused by dermatophytes, a group of filamentous fungi with the ability to invade the outer layer of the skin, hair, and nails. The three main general groups responsible for these infections are the Trichophytum, the Mycosporum, and the Epidermophytum. The causal agents that we're going to find are going to be the Trichophyton tonsurans and the Mycosporum canis. This will be normally around pre-adolescent children. The tinea capitis is limited to the scalp, eyebrows, or eyelashes. This is the most frequent manifestation of infection by dermatophytes in children, and it usually decreases around the age of 10 or 11 years. The symptoms that we can find. There's going to be minimal pruritus with or without hair loss, severe edema, and there could be permanent scars in inflammatory carrion lesions like the one that we see in the middle. For the examination, will be done by Wood's light, which will give the areas affected by the mycosporum a greenish fluorescence. And before starting treatment, it is always recommended to confirm the diagnosis by collecting material by swabbing or brushing techniques. The treatments for superficial mycosis consist in eliminating the risk factors of development and multiplication of the fungi throughout actions at local and systemic levels. For that, we're going to use a shampoo with 2% ketoconazole and 1% selenium, which are recommended as topical helpers as they reduce the viability of fungal spores present in the hair and reduce their potential for infection. For the drug use, we can use three different ones. The griseofulvin, which is around 20 to 25 milligrams per kilogram per day throughout 6 to 8 weeks. The itraconazole, which is 5 milligrams per kilogram per day for 4 weeks. And the terbinafine, which its dose can go from 62 milligrams up to 250, depending on the weight and age of the patient.
Tinea corporis. Tinea corporis is a type of dermophytosis, a superficial skin infection located in all hairless regions of the human body, except for the palms, soles, and groin. It is caused by the dermophyte fungi of the genera Microsporum, Epidermophytum, and Trichophytum. Okay, the clinical signs, the lesions are circular, erythematous, scaly flakes that are usually itchy. They are seen on the thorax and upper limbs and the face. It starts with a papule and or pinkish macula. The diagnosis is made by clinical picture and can be assessed in the mycological examination. The treatment consists in something called Whitfield's ointment, and also we can use 4 daily tablets of griseofulvin M, and also all the derivatives of the imidazole are used. And the hygienic measures are very important so the treatment can be consolidated.
Tinea pedis is the term used for dermatophyte infection of the sole of the feet on the interdigital spaces. Tinea pedis is most commonly caused by the Trichophyton rubrum. Dermatophyte initially endemic only to a small part of the Southeast Asian and little part of Africa and Australia. Other etiological agents are the Trichophyton mentorophytes and the Epidermophyton floccusin. Tinea pedis is thought to be the world's most common dermatophytosis. Symptoms: commonly tinea pedis patients describe a separated scaly soles and often faintly featured between the toes. Less often, patients describe a vesicular or ulcerative lesions. Some tinea pedis patients, especially elderly people, may simply attribute their scaly feet to dry skin. Diagnosis is a spray of tinea pedis or a direct potassium hydroxide staining for fungal elements. You can also use a keeping-specific stains fluorosol black E, chalcofluor, mycoser or microbiotic agar, and the immunochromatography, but it has been proved to be the less effective to diagnose the tinea pedis. Tinea pedis can be treated with topical or oral antifungals or the combination of both. Topical agents are used for 1 to 6 weeks depending on manufacturer's recommendations. Fluoroconazole is an imidazole topical cream that is applied once daily for 2 weeks. Notifying gel or cream to person is indicated for interdigital tinea pedis in adults and adolescents. An iconazole foam is now available, and regarding itraconazole, there may be some advantages to giving itraconazole with whole milk to increase the absorption. Thanks.
Good afternoon, Professor. My group and I are going to present about the topic known as onychomycosis. The team members are Virginia Martinez, Umbrano Hamad, Ana Silgado, and myself, Nelson Santamaria. Let's start with the introduction, basic stuff about this topic. We know that onychomycosis is known as nail top. The distribution around the world is wide. It's considered one of the most common nail diseases. It's most often seen in ages between 20 and 40, but it's even seen in elders in a 48%. It affects most of the time in a 70% the nails of the toes, in a 27% the nails of the hands, and in a small 3% the nails of the hands and feet. For the anatomy, we gotta know that a fingernail is produced by living skin cells in the finger. A fingernail consists of several parts, including the nail plate, the visible part of the nail, as shown in the picture, the nail bed, the skin beneath the nail plate, the cuticle, the tissue that overlaps the plate, and rims of the base of the nail. The nail folds, the skin folds that frame and support the nail on 3 sides, the lunula, the whitish half moon at the base of the nail, and the matrix, the hidden part of nail under the cuticle. Fingernails, as we know, grow from the matrix. The nails are composed largely of keratin, that is a hardened protein that we see that is found in hair and nails. As new cells grow in matrix, the older cells are pushed out, compacted, and take on the familiar flattened, hardened form of the fingernail. For the etiology, we've seen that it's caused by dermatophytes, yeasts, and mold. Those 3 are opportunistic. The agents are the ones shown in the picture that are Trichophyton rubrum, Fusarium species, and Candida species. The dermatophyte Trichophyton rubrum causes the disease in a 70 to 85% of the times, but it's also shown that Candida species, such as Candida albicans, can cause in a 70%. In a small percentage, like 4%, it's caused by mold. And lastly,
clinical presentation of onychomycosis. Distal lateral subungual onychomycosis is the most common type of onychomycosis. We are going to see this type of onychomycosis as an invasion of the nail bed and underside of the nail plate at the beginning of the eponochium, with a mild inflammation resulting in a subungual hyperkeratosis and parakeratosis. The nail plate is going to get thick with a yellow to brown discoloration that we can see in this picture here. Sometimes it can have onycholysis, that is a detachment of the nail bed from the nail plate. Yes. Proximal subungual onychomycosis is a white discoloration of the proximal nail plate that spread distally. The clinical presentation include a subungual hyperkeratosis, a proximal onycholysis, a leukonychia, and the destruction of the proximal nail plate. And is a common type of onychomycosis in patients with HIV and is normally considered an early clinical marker of the HIV infection. Why superficial onychomycosis is going to affect the surface of the nail plate rather than the nail bed. The discoloration is white and it can be recognized by the presence of white island on the external nail plate. The surface is going to be like super flaky or crumbly, and the onycholysis is not a common thing in this type of onychomycosis. Phyton endonite onychomycosis is a type of fungal infection by Trichophyton sudanense, Violaceum, or rubrum. And the clinical presentation of this type of onychomycosis is a milky white discoloration of the nail plate without a hyperkeratosis or onycholysis. In the histopathology, we are going to see a lot of fungi, filaments confined to the nail plate without the nail bed. The Candida nail infection occurs in a person with a chronic mucocutaneous candidiasis and is caused by a Candida albicans. We are going to see an invasion of the entire nail plate, onycholysis, and paronychia. In the beginning stage of this type of candidiasis, we are going to have paronychia, also called whitlow. Is the most common type of candidiasis in the nail. The nail matrix become infected with a transverse depressions called bow lines may appear in the nail plate, and the persistent infections turns to a nail convex, irregular, and finally dystrophic. Then we have Candida granuloma. The Candida is going to invade the nail plate, and this may affect the entire thickness of the nail. The last stage will be a Candida onycholysis, and this occurs when the nail plate has separated from the nail bed. It's more frequently seen in the hands than in the feet. Total dystrophic onychomycosis is the final stage of the nail disease and is described as a crumbled nail plate with a thick nail, as we can see here, with a yellow-brown discoloration. and the nail plate is completely destroyed. We also have a peritonitis by Candida, we can see in this picture here. Fungal melanocchia is a type of onychomycosis that is caused by a fungi. We can see this type of onychomycosis as a brown to black pigmentation of the nail. We also have a non-dermatophyte mold onychomycosis that we can see as a white superficial onychomycosis or a distal one and a proximal one.
Okay, onychomycosis diagnosis. To start, the treatment shouldn't be established solely on the basis of clinical data. Despite the fact that about 50% of nail dystrophies are caused by fungi, the cost for diagnosis is always inferior than that of performing unnecessary or inappropriate treatment. It is important to also know the genus and species of isolated fungi, since the therapeutic orientation is different in each case. Lab analysis involves evaluation of nail clippings and subungual debris from the involved portion of the nail. Samples should be collected after cleansing the area with 70% isopropyl alcohol to prevent contamination. And once the specimen has been obtained, office microscopy can be performed by preparing these samples with potassium hydroxide, or KOH, in 10% to 20% solution. The KOH will dissolve the keratin, leaving the fungal cell intact. The commercial labs may use KOH with chalcoflower white stain, which binds to cellulose and enhances the fungal components in fluorescent microscopy. So the ID of hyphae and pseudo-hyphae or spores confirms the infection, but does not identify the organism. To identify the organism, cultures can be performed in a lab. Samples should be sent in a sterile container, and results are usually available in 4 to 6 weeks. Histologic evaluation can also be helpful for ID of the organism and can provide results within 24 hours. Also, periodic acid sheaf staining called PAS and methanamine silver stains are used. And also the polymerase chain reaction testing, known as PCR, has been shown to be more accurate than cultures, and results can be available in 3 days. However, it is not yet widely available. In differential diagnosis, some conditions that could mimic onychomycosis are chronic paronychia, which is a chronic inflammation of the proximal paronychium, usually caused by Streptococcus or Staphylococcus, or Candida, found on smear and culture, and it's very common in children. Also, chronic dermatitis, which is a subungual dermatitis with hyperkeratosis, and the lichen planus, which usually also affects the fingernails. Psoriasis, which presents with nail pitting, splinter hemorrhages, and yellow-gray or silvery white nails. Also footwear lesions and some tumors, such as Bowen's disease, fibroma, melanoma, and some other conditions like alopecia, onycholysis, diarrhea, and scabies.
Okay, treatment. The treatment, it's based on 2 different types of therapies. We have the topical therapy and the systemic therapy. The topical therapy should be considered first because of its few side effects. It's indicated in nail yeast infection, but it can also be used in cases of Taenia unguinum in superficial mycosis caused by opportunist fungi and as a complement to systemic treatments. Here we have 3 different types of medications. First, I'm going to talk about the amorolfine. The amorolfine is a broad-spectrum fungicide. It works by inhibiting ergosterol synthesis in the fungal cell membrane. It's applied once or twice a week for 6 months in cases of fingernails and 9 to 12 months in cases of toenails. Prurite and dermatitis are its main side effects. Then we have the cyclopyroxolamine, that it's a broad-spectrum fungicide. It inhibits the absorption of potassium, phosphate, and amino acids, causing the cell death. During the first month is applied every 48 hours. During the second month is applied twice a week, and from the third month is applied weekly. Is applied weekly. We don't have to exceed 6 months of therapy. The thioconazole is a fungistatic and a broad spectrum. It belongs to the azole family and works by inhibiting ergosterol synthesis. It's applied twice a day for a variable period of time, depending on the type of fungus and on the type of infection. The systemic treatment, it's mainly indicated for the treatment of Taenia unguinum, nail fungal infection, and some aggressive yeast infection with nail plate destruction, or especially when topical treatment fails. Here we have two different types of medications. We have the terbinafine and the itraconazole. The terbinafine is prescribed in a doses of 200 milligrams per day, and it's used in a period of time of 12 weeks in feet and 6 weeks on hands. The itraconazole is a synthetic triazole antifungical that works by inhibiting the synthesis of ergosterol. It's prescribed in a doses of 200 milligrams per day for 12 weeks in toenails and 6 weeks in fingernails. The doses and the time of the treatment can vary in the type of infection and in the type of fungus.
In the preventive steps that the person is to have is to keep their feet dry. That's the main one. The person, if he or she is performing any type of sport, she or he may want to buy a special dry powder. The person needs to keep a basic hygiene in hands and feet. You gotta detect if there's any alteration in your nail regarding the appearance. And definitely the last one that you shouldn't do is share your shoes with family members, friends, and especially the ones that have the disease. Here we have a picture of the book we base our information on. That's it for our topic. Thank you for your attention.
Pityriasis versicolor. Generalities. Pityriasis versicolor, or also known as tinea versicolor, is a superficial mycosis that is caused by hypochromic or hyperchromic spots with flakes that predominates in areas such as the thorax, neck, and upper arms. Usually when treated, it presents an adequate response to it, but recurrences are very frequent. Mycosis is endemic in tropical areas. The prevalence varies from 0.8 to 30 or 50, mainly in places like Samoa, Fiji, Central America, and some regions of Africa and the Mediterranean. It can appear at any age, but affects mostly between the ages of 20 and 45. It affects both sexes, but it predominates more in male. It has seen that infants can suffer from pityriasis, but it is usually rare during childhood. Etiopathogenesis. Tinea versicolor is caused by the dimorphic lipophilic organism in the genus Malassezia, formerly known as Pythiosperm. Malassezia is naturally found on the skin surfaces of many animals, including humans. The organism can be found on skin regions, demonstrating cutaneous diseases. In patients with clinical disease, the organism is found both in the yeast stage and the filamentous form. This organism is favored by heat, humidity, sweating, sebum production, use of occlusive clothing made out of synthetic material, and also in the application of topical and systemic glucocorticoids, or seen also in immunosuppression cases. Even though malassezia is a component of the normal flora, it can also be an opportunistic pathogen. Clinical presentation. The lesions usually has a distribution in the thorax, back, and proximal part of the extremities. They rarely extend to the neck and forearms. In children, they may affect areas such as the face, forehead, and preauricular regions, as seen in the second picture. And in infants, it can affect the diaper area. The lesions are chronic and asymptomatic, although occasionally they can cause mild itching. All of the lesions are isolated, but they can come together and form confluent patches as seen in the first and fourth picture. They measure up to 2 to 4 millimeters in diameter or to 1 or 2 centimeters. It is usually characterized by hypopigmented or hyperpigmented macules or patches, as I mentioned before. Malassezia folliculitis affects young people with a history of treatment with glucocorticoids or antibiotics, as well as patients with diabetes or immunosuppression, as I mentioned before. Like, for example, in transplant recipients and in AIDS patients. The lesions usually predominate in the trunk, neck, and upper arms. It consists of pruritic follicular papules with keratotic plaque or pustules, seen in the upper right picture.
Histologic findings. The organism that causes tinea versicolor is localized on the stratum corneum. Malassezia can be detected by H&E stain alone, although periodic acid Chief or methenamine silver staining are more confirmatory. The epidermis reveals mild hyperkeratosis and acanthosis, and the mild perivascular infiltrate is present in the dermis. The clinical presentation of tinea versicolor is distinctive, and the diagnosis is often made without any laboratory documentation. The diagnosis is usually confirmed by potassium hydroxide or KOH examination, which demonstrates the characteristic short cigar butt hyphae and spores with short mycelium. Scratch sign or Besnier sign is when barely visible fine scales are made to stand out by scratching the lesion. The ultraviolet black light or wood lamp can be used to demonstrate the coppery orange fluorescence of tinea versicolor. Special media are required for culture, and they are rarely obtained since the diagnosis is usually clinically suspected and can be confirmed by KOH preparation. Differential diagnosis is based on pityriasis alba and hypochromic solar dermatitis, vitiligo, erythrasma, pityriasis alba, achromatic or pigmented nevi. Tinea versicolor can be successfully treated with various agents. Effective topical agents include salicylic acid and sulfur, topical imidazoles in creams or solutions, such as ketoconazole and clotrimazole, topical allylamines like terbinafine and naftifine. Some oral agents, such as fluconazole and itraconazole, are the preferred drug for oral treatment. Promiconazole has also been used in the management of tinea versicolor. For long-term monitoring, tinea versicolor has a high rate of recurrence, so prophylactic treatment with topical or oral therapy on an intermittent basis is necessary to prevent recurrences in most cases. After treatment, some patients might be left with residual hyperchromic patches with a negative scratch sign that will fade away over time. Here are some other examples of how the clinical presentation of tinea versicolor can be seen on the thorax, back, neck, and upper limbs.
Piedra, which means stone in Spanish, is an asymptomatic superficial fungal infection of the hair shaft. Since 1911, it's divided into white piedra and black piedra. White piedra consists of lightly pigmented nodules. They are loosely attached and with a gelatinous sheet with a soft texture. It affects the beard, the mustache, the pubic hair, the axillary hair, the eyelashes, and the eyebrows, and the etiological agent is Trichosporum species, mostly Trichosporum asahi, And also, others say that Trichosporum ovoides is the one responsible for the least common infection of white powder in the scalp. The source of infection can be in the soil, air, water, vegetable matter, sputum, or on the body surface. It predominates in temperate and semi-tropical climates, such as the ones we see on Asia, Europe, and the southern parts of the USA. Risk factors include bad personal hygiene, working on unsanitary conditions, excess of sweating, sexual contact, and immunosuppression, such as in patients with HIV. We see it in both sexes, but it's more common on young men. The most common complication is the loss of the structural integrity of the hair shaft that leads to breakage, and this also happens on the black pierra we'll see later. On the diagnosis, the microscopic examination, it's done with a hair sample prepared with 10% potassium hydroxide and a fungal stain that can be black chlorazole or blue-black Parker ink. The nodules we see here are amorphous. The hyphae are pigmented and they are very loose. Blastoconidia, arthroconidia, they are attached to the hair shaft. In the culturing, Trichosporum species grow better at 28 to 30 Celsius degrees. Trichosporum asahi, which is the most commonly associated species, rarely grows on saburo-dextrose agar due to an inhibition by the cyclohexamide. The treatment of choice is the shaving and clipping of the hair, and also on medical treatment we have imidazoles, cyclopyroxalamine, selenium sulfur, precipitated sulfur on petroleum, chlorhexidine solution, castellani paint, zinc propbutane, and amphotericin B lotion. Also, for the not so common infection on the scalp, the treatment is itraconazole. In the black pierra, you'll see that the nodules are dark and they are very attached firmly to the hair shaft. They vary in size and they feel hard. The most affected area is the hair shaft of the scalp, and the etiological agent is the Piedraia ortae, which seems to be in the soil. However, the infection has also occurred in organisms in stagnant water and crops. It is common in tropical regions, which has high temperature and humidity, such as South American countries, and the risk factors are the same and also very long hair. It affects both sexes and it has the same complication as white pierra. The diagnosis is done in the same way, and the hyphae here are very compact. They are packed and pigmented. The asci are in group of 8, and we see ascospores attached to the hair shaft. In the culturing, the Piedraia ortae grows better at 25 degrees. It grows slowly on agar saburo-dextrose, and it's not inhibited by the cyclohexamide. It is also important to say that mycological culture on mycosol plus molecular identification may be used to confirm the diagnosis, and in the differential diagnosis, there is an overlap in white pierra and black pierra, which includes pediculosis pubis and capitis, hair cast, monilithrix, trichorexis nodosum, trichomycosis axillaris, and trichomycosis pubis. And the treatment of choice is also shaving and clipping. It responds very well to oral terbinafine. And also ketoconazole shampoo and keratolytics such as salicylic acid.
Tinea nigra. Tinea nigra is a type of dermatomycosis, a fungal infection of the skin, which affects the stratum corneum, and it is characterized by a black or brown patch on the skin. It is caused by a fungi called Fortea wernickii, which lives on decaying wood, soil, or sewage. The fungi can be contracted by being exposed to any of those materials and by suffering an injury that involves open skin. It is a polymorphic demariaceous fungi that initially grows as a black cyst and then becomes a mold. It is halotolerant and halophilic. Another pair of etiological agents are Cladosporidium castellani and Phoma hibernica. The highest incidence is reported in 4 areas of the world: Central and South America, especially in Panama, Brazil, Colombia, and Venezuela; Asia, especially in Japan, Sri Lanka, India, and Burma; Polynesia, the coast of Africa. It is not often seen in the United States and in Europe, and most of the cases come from another region. At higher risk are children, young adults, women, and those patients with hidradenitis suppurativa in plants and palms. Tinea nigra produces black or brown patches on the skin. The affected area tends to expand over time. It has an irregular shape and often dark borders. Sometimes the area becomes itchy or flaky. The patches usually appear on the palms of the hands and the sole of the feet, but occasionally you can find them in the neck and trunk. The diagnosis is made through a clinical history of the patient, a physical exam, scraping of the lesion, a lab culture of the material collected from the scraping. A biopsy is not often performed but can be helpful, and potassium hydroxide test. Most of the treatments are topic, including Whitfield ointment, 2% ketoconazole cream, 2% miconazole cream, and 5 to 10% salicylic acid ointment. In terms of prevention, you must be careful when traveling to areas where you may be exposed, and you must avoid contact with potentially infected materials such as decomposing wood, dirt, sewage, or organic manure. The differential diagnosis include other potential causes, such as skin pigmentations as melanocytic nevi, lentiginous, melanoma, and dermatitis neglecta, skin decolorations from metals, lichen planus palmaris, which you can see at the top of the slides, or fixed rock eruptions, which you can see at the bottom of the slides. Thank you.
Up next, we're going to be talking about candidiasis. The most frequent species that causes candidiasis is called Candida albicans, specifically serotypes A and B. It is a yeast fungus that is commensal in the gastrointestinal tract under normal conditions. However, there are certain conditions in which it may turn pathogenic, such as immunocompromised patients, a humid environment, patients receiving antibiotic therapy, pregnant women, women receiving contraceptives, and even in patients with parenteral nutrition or in neutropenic states. Oral candidiasis can be presented in two different ways, an acute pseudomembranous that is also called thrush, or a chronic pseudomembranous in AIDS patients. Candidiasis is the most frequent fungal infection in HIV-positive patients and one of the most frequent in its natural history. It is usually superficial in nature with exclusive involvement of a mucosa, with invasive forms such as candidemia being less frequent. It can affect the oral, thrush, pharyngeal, or even vaginal mucosa, in which it appears as raised and white patches that are easily scraped off with a spatula. Its clinical manifestations can include an acute or chronic erythema, chronic plaque, a chronic nodule, a middle rhomboid glossitis, and it can be either erosive or painful.
Candidal onychomycosis, it represents 5 to 10% of onychomycosis by yeast. Clinical presentation, paronychia, onycholysis, and periingual inflammation. Flexural candidiasis, also known as intertrigo, can present in areas such as inguinal folds, submemifolds, armpits, and interdigital area. The interdigital presentation is also known as erotio interdigitalis plastomycetica. It affects the interdigital folds of the hands due to chronic maceration, humidity, and frequent hand washing. There's also an intense red erythema with vesicles and pustules. Candidiasis folliculitis, frequent in parenteral heroin addicts. Pustules can appear on scalp and beard and may be accompanied by chondrocostal involvement, endophthalmitis, general discomfort, and fever.
Okay, so about the therapeutic guidelines, we have the general measures like skin cleansing and hygiene. We also need to decrease the risk of reinfection by do not sharing towels or clothes. Try to do not wear occlusive shoes or nylon fabric, and also try to do not walk barefoot. About the oral antifungals, we have the topical antifungals. For example, for superficial candidiasis of the oral and pharyngeal mucus, it may respond to the topic treatment of nystatina, and for the vaginal candidiasis, it may respond to fluconazole ovules. Biological findings in the epithelium's horny layer, there appear to be yeast clusters and pseudofilaments such as blastoconidia and pseudohyphae. In the diagnosis, it is based on the cultivation of the exudate from the affected area, and about the treatment, it will be discussed in details in the next slide, but basically it can be treated or it may respond to nystatina.
The mycetoma. Mycetoma is a chronic granulomatous disease of the skin and subcutaneous tissues, which sometimes involve muscle, bone, and neighboring organs. It is characterized by tumefactions, abscess formations, and fistulates. It typically affects for lower extremities, but it can occur in almost any region of the body. Mycetoma predominates occurs in farm workers, but they can also appear in the general population. The history. The condition was first described in mid-1800 and was initially named Madura foot, after the regions of Madura in India, where the disease was first identified. In 1860, Cartier named the condition mycetoma, describing its fungal etiology. In 1872, Carter further proposed the terms melanoid and ochroid, and attempted to classify two diseases into two varieties on the basis of the black or pale-colored granules produced by the etiology agents. Epidemiology. Mycetoma is endemic around the Tropic of Cancer in tropical, subtropical, and temperate regions. Sudan, Mexico, Venezuela, India, Pakistan, Senegal, and Somalia have the highest incidence of diseases worldwide. The United States, Asia, and other Latin American countries have reported cases less frequently. For sex, mycetoma is more common in men than in women. The male-to-female ratio is 3 or 1. For age, mycetoma predominates in individuals aged 40 and 20 years. Pathologic agents. More than 20 species of fungi and bacteria can cause mycetoma. Nocardia species, especially Nocardia brasiliensis, is the most commonly implicated actinomycetes. Mycetoma is characterized by the formation of grain, which contain aggregates of the causative organisms that may be discharged onto the skin surface through multiple sinuses. The characteristic color of the grains can assist in the identification of the specific etiology agents. The agents that cause actinomycetoma are always aerobic and are sometimes weaker acid fast.
Physiopathology. The body parts affected most commonly in persons with mycetoma include the foot or lower leg, with infection of the dorsal aspect of the forefoot being typical. The hand is the next most common localization. However, mycetoma lesions can occur anywhere on the body. Lesions on the chest and back are frequently caused by nocardia species, whereas lesions on the head and neck are usually caused by Streptomyces somalensis. A neutrophilic response initially occurs, which might be followed by a granulomatous reaction. Spread occurs through skin facial planes and can involve the bone. Hematogenous or lymphatic spread is uncommon. Human-to-human or animal-to-human transmission has not been described for eumycetoma, but nosocomial transmission of Nocardia versinica, one of the agents of actinomycetoma, is postoperatory surgical site infection has been reported. Prognostic. Mycetoma is usually painless. Individuals who are affected medical attention mainly because of tumefaction and draining sinuses. In case affection, the thorax or the head mycetoma can be potentially fatal. because of the spread of microorganisms on adjacent organs. Rarely, the disease spreads by hematogene dissemination, nocardia, asteroides, or ana brasiliensis. Mycetoma tends to be a more chronic disease, and success with medical therapy is observed in only about 40% of cases. If the response is partial or negative to medical treatment, surgery of the affected area should be performed at antifungal drugs continuing until complete remission of the disease. Treatment. Medical care. In the treatment of mycetoma, antibiotic or antifungal therapy should be attended first and may need to be combined with surgery, especially for mycetoma lesions in the extremity. Surgical care. Surgery is recommended for localized mycetoma lesions that can be excised completely without residual disability. Surgical reduction of large lesions can improve the patient's response to medical treatment. However, partial surgical resection without subsequent use of approved antimicrobial or antifungal agents is prone to failure.
Good afternoon, Professor and fellow classmates. Today my group is going to present our topic of actinomycosis. We will be touching on the following topics: the disease, its etiology, signs and symptoms, the diagnostic, some histological samples, its treatment and management, and if time allows, a clinical case. Actinomycosis is a rare chronic disease caused by Actinomyces species, an anaerobic gram-positive bacteria that normally colonizes the human mouth and digestive and genital tracts. It can be confused oftentimes with malignancy, tuberculosis, or nocardiosis as it spreads continuously and progressively, forming cold abscesses. Its etiology is that actinomyces are non-spore-forming gram-positive rods. The bacteria form branching filamentous rods. While more than 30 species have been described, the one that is most prevalent in human infections and found in most clinical forms is the Actinomyces israeli. It accounts, along with the Actinomyces gerencerae, for about 70% of cervicofacial infections.
The characteristic actinomycosis lesion corresponds to an indurated area with multiple small communicating abscesses surrounded by granulation tissue. These lesions tend to form fistulous tracts that communicate with the skin and drain purulent secretions containing sulfur granules, round or spherical, generally yellowish in color, and less than 1 millimeter or equal to 1 millimeter in diameter. The sulfur granules, which do not contain sulfur, are so named because of their yellow appearance. They are made up of a tangled mass of the branched filaments of actinomyces, and the infection spreads to adjacent tissues, but rarely does it spread hematogenously.
The regions most affected are cervical facial area, 50 to 60%, thoracic, 15%, pelvic abdominal, 20%, brain, 2%. So, the definitive or confirmatory diagnosis of actinomycosis is that through the histopathological study. The histopathological characteristic to confirm diagnosis of actinomycosis is the presence of actinomyces plus the exemplary Hopley phenomenon. This sign is a pathognomic characteristic of the disease, which consists of the interface between bacterial colonies and the exudate of polymorphonuclears with the deposit of eosinophilic material.
We have various histological samples and various figures. In figure 1, we see a sulfur grain and it is seen in a pleural biopsy. This is a hematoxylin Nielsen stain for 100X. Then we see figure 2, which is also a sulfur grain, and the bacteria is observed forming a palisade in a pleural biopsy again. This is also a gram stain. In figure 3, we see gram-positive bacilli, and these are seen basically on chains in a pleural biopsy. This is also a gram stain, and this is 1000x. In figure 4, we see sulfur grain, the sulfur grain with bacteria, and it is observed the bacteria forming a pellicide in a pleural biopsy. Again, this is a Gomori-Gorod stain for 100x. And finally, in figure 5, we see a sulfur stain without resistant acid-alcohol bacteria, and it is observed also in a pleural biopsy. This is a Ziel-Nielsen stain for 100x.
Okay, the treatment. The first choice of antibiotics are penicillin type beta-lactam, penicillin G, amoxicillin, or oral penicillin G, or ampicillin. In allergic patients, it can be used macrolides like erythromycin, lincosamines such as clindamycin or lincomycin, tetracyclines. The duration of the treatment with antibiotics should be prolonged from 2 to 6 weeks, being able to be in the first day parenteral and later to change to oral route, valuing the evolution having oral treatment up to 12 months.
So here we have two cases, and you are welcome to review them on your own time. We have information on the description of the case and the pictures, and finally the treatment.
About sporotrichosis. Next. Sporotrichosis is a subcutaneous mycosis infection caused most commonly by the fungus Aspergillus skingi, which is found on decaying vegetation, rose bushes, twigs, hay, sphagnum moss, contaminated soil, and even cats. Because of its tendency to present after a thorn injury, it is also called rose gardener's disease. It might present particularly on the face and limbs and is characterized by nodules that follow the path of lymphatic vessels. Next. Epidemiology. It is more frequent in tropical and subtropical areas such as South Africa, Japan, Australia, and America, going from Florida in the United States to Uruguay. It is more frequent in farmers, gardeners, florists, and carpenters. It may affect everyone, but there's a tendency on people such as kids and people from 16 to 30 years old. Next. As curiosity goes, regarding Panama, we found an article published in 2018 about, next, zoonotic sporotrichosis related to cat contact, first report from Panama and Central America. Next. Here's a picture from the patient in the article. He was a healthy 34-year-old man from La Espiga, Chorrera. Next.
The classification is based on if it is presented as cutaneous, disseminated, or extracutaneous. The clinical characteristics of lymphatic form are initial chancre consisting of a nodular or ulcerated lesion. In 2 weeks, a chain of painless erythematous violaceous lesions develop that follow the path of the lymphatic vessels in that specific area and can ulcerate. Those are located mainly in the upper and lower limbs and in the face.
Fixed sporotrichosis shows infiltrated semilunar plate that can ulcerate and cover with scabs. It is surrounded by an erythematous violet halo. Next. Disseminate sporotrichosis. Disseminate cutaneous. It affects integuments and usually shows an adequate response to treatment. Systemic. There will be manifestations such as weight loss, fever, skin lesions that can ulcerate and form plaques. Fungal arthropathy of the knee and tibia may occur. Next.
There are different histopathological findings such as suppurative granuloma in the first picture. In the other picture, we can see an astral body which can lead to signs of sporadic process. Next. About lab, the intradermal reaction to sporotrisin González Ochoa is a phase method to diagnose sporadic crisis in 48 hours, but it doesn't mean if it's positive that there is a current active sporadic crisis. It is considered positive when the individual had erythema with induration equal to or greater than 8 millimeters. To confirm diagnosis, culture may show cream or black colonies typical of a shanking. Next. Regarding skin in adults, it is traditionally treated with saturated potassium iodide solution given orally 3 times per day for 3 and 6 months. Urine or lesions have gone. Beware of side effects such as gastritis, confusion, arrhythmias, numbness of hands and close follow-up of patients with renal insufficiency or using ACE inhibitors. Also, itraconazole can be used orally for up to 6 months. In kids, it must be used only 15% to 33% of the adult doses. 10.
Good afternoon. Today my group will talk to you about chromoblastomycosis. A little bit about the history. Chromoblastomycosis was first described in 1914 by a German doctor living in Brazil called Max Rudolph. It is now widely accepted that 4 different genera causes the chromoblastomycosis. What is chromoblastomycosis? Well, it's a subcutaneous mycosis that affects the skin and the subcutaneous cellular tissue. It is preferably located in the lower extremities and it's characterized by verrucosus, nodular and atrophic lesions of chronic evolution and difficult treatment. It is originated from a black fungus. Epidemiological data, it predominates in rural areas, particularly in tropical and subtropical climates. It affects more frequently men between 30 and 60 years old, usually to farmers due to the exposure to the contaminated material. It's not transmitted from person to person and is considered an occupational disease. The most endemic or the most important endemic area is the Huasteca, which includes valleys, rivers, and temperatures from 20 to 25 Celsius. The natural infection is found in dogs, cats, horses, frogs, and sea lions.
The causative agents are black fungi with low pathogenic power, thermosensitive at 40 to 42 Celsius. It is likely to predispose malnutrition and protect the hormonal status. The possibility of genetic susceptibility and partial immunosuppression against fungal agents has been considered. The fungus penetrates by traumatic inoculation and develops by proximity and sometimes lymphatically. In its parasitic phase, it manifests itself in the form of fungus cells which multiply by direct division and sometimes emit filaments. Immune mechanisms are not fully understood. Cellular immunity seems to be affected according to the clinical picture. In warty lesions with many fungal elements, Th2 response is suggested, and erythematous camous plaque with few elements, a Th1 response is suggested. When measuring the transformation growth factor beta, it is shown that high levels will correlate with active lesions in persistence and mechanisms and fibrosis, while it decreases translate into fungal destruction. An initial increase followed by a decrease will indicate response to treatment. There are 10 causal species that have been reported. Phyllophera verrucosus is one of the common ones, and Fonsecae pedrosoides another most frequent one in Mexico. The wide genetic variety has been recognized in black fungi throughout polymerase chain reaction and restriction fragment length polymorphism studies. This has led to placing in two genetically heterogeneous groups, and the P. verrucosa is in one of those groups. And P. verrucosa shows different models of mitochondrial DNA. The models have been divided into 10 types of mitochondrial DNA and are located in 3 groups. The strains from Japan and United States are in group A and B, the one in China is in group B, and those in South America are in group B and C. The causative
Clinical manifestations. The site most commonly affected are the lower extremities. As the chromoblastomycosis lesion develops, it assumes a scaly and infiltrate aspect, generally leading to either of the two most common clinical variants, nodular or plaque. In both types, the surface is verrucose. The nodular type of lesion normally develops into verrucose, pedunculate, cauliflower-like florets. The plaque is peripherally with an active raised border, leaving the central heel area with atrophic and jaw. On the surface of both types of clinical variants, numerous black dots may be observed. A more purulent material covering small ulceration is commonly. The most common complication is bacterial infection, in chronic case there may be deformations of the region due to lymphostasis subsequent to fibrosis and even elephantiasis. So this aspect is included within the mosey foot syndrome. Histopathological findings. There is hyperkeratosis, acanthosis, or pseudoepitheliomatous hyperplasia in epidermis. A suppurative and tuberculoid granuloma with giant Langerhans cells is observed in dermis. The fumagoid cells are pigment and can be found without the need for special staining. Laboratory studies. In the direct examination with potassium hydroxide, the fumagoid cells are found which measure 4 to 8 micrometers, are spherical, have double membrane, and can emit filaments. Molecular studies serve for identification, taxonomic classification, and epidemiological phylogenetic studies of causal agents.
Differential diagnosis. Dermatologic manifestation of aspergillosis, leishmaniasis, warty tuberculosis, squamous cell carcinoma, aspergillosis, ringworm, psoriasis, mouseoma, coccidioidomycosis, warty lymphostasis, secondary syphilitic. Medical care. Several authors indicate itraconazole as the best choice of therapy. Daily doses range from 200 to 400 milligrams and results vary greatly. Adverse effects are not common, but efficacy is not as high as one would desire. The severe cases should be treated for several years. However, a complete cure is rarely reached. Especially in severe cases, this result might be because of the predominantly phagocytic mechanism of action of the drug. In numerous cases, drug withdrawal led to relapse. Heat therapy is another treatment. The use of pocket worms has proven successful in the treatment of a limited number of cases. Surgical care. Cryosurgery with liquid nitrogen can be used to treat chromoblastomycosis, especially localized lesions. Combination therapy with cryotherapy and terbinafine has been advocated, as there is no standard treatment and high rates of relapse. Topical imiquimod has been used with substantial improvement documented both with and without concurrent oral antifungal therapy.
Good afternoon, doctor. Next, we will introduce the topic coccidioidomycosis, presented by Ismail Alhishi, Luis Equijarrosa, and Milagros Serrano. It is a systemic mycosis, opportunistic in immunodeficient primary pathogen immunocompetent, also known as Posadas and Wernicke's disease, California disease, San Joaquin Valley fever. It mainly affects the respiratory system, spreading to other organs, and infrequently as a primary on the skin caused by Coccidioides ignitis and Coccidioides posadaci. It is often seen in sandy soil environment. They have a parasitic phase in the tissues in form of spirals of 10 to 18 microns with a double membrane containing endospores of 2 or 3 microns. They have an infection phase in the environment. It contracts by inhaling fungi from the soil and when broken, cause the release of arthroconidia that spread through the air. Infection occurs by inhaling arthroconidias, which are found in the bronchioles and alveoli, and develop spirals contain endospore that, when released, spreads to the tissues.
Okay, let's follow with the clinics. We could see the pulmonary primary form. It's the most common from the forms of this pathology. It could appear in the first week or in the period from the first and the third week. It's 60% asymptomatic and the 40% remain, it could be symptomatic. You could have like fever, night sweats, coughing, pleuritic pain, and manifestations of hypersensibility. It could spontaneous resolve in 30 to 60 days. It's very intense exposures and it could be more difficult to resolve in immunosuppressed patients. You could see multiple diffuse pulmonary infiltrates, cavitation, acute respiratory failure, and probably death. You could see them, the progressive pulmonary form. It's more drastic in diabetics and immunocompromised persons. Symptoms that do not resolve in 2 weeks or in 4 weeks. It presents as cavitary or nodular lesions, pulmonary cavity disease with fibrosis, and you could see miliary pulmonary disease. Then we could see disseminated disease. It's like 0.2% of patients with pulmonary lung disease. Mainly, you could see this form in immunocompromised persons, patients of diabetes, pregnant women, Filipino persons, or Black people. The symptoms could be skin and central nervous systems, bones, joints, and genitourinary system, the principal places that you could see damage from this form of the pathology. Generally with acute progressions and quickly leads to death. However, it sometimes progresses in slow motion. Then we could see skin disease. This is the most important part for us. Generally, it's by dissemination. It rarely occurs from traumatic primary inoculation. It predominantly affects the face, like you could see in the image A, and you could see polymorphic lesions like papules, warty lesions, plaques, pustules, and abscesses. The primary cutaneous form occurs by inoculations, and you could see this in the laboratories or in an autopsy. But in endemic regions, may follow by trauma. Then we could know the mechanism. In primary cutaneous coccidioidomycosis, the mechanism of infection is by inoculation after trauma with material contaminated by the fungal agent. The incubation period is from 1 to 4 weeks, like a month, more or less. In people who work the land, it is considered an occupational risk disease. This is something very important to have in mind. Then we need to know that there is a tuberculoid granuloma with epithelioid and giant cells and something causes necrosis or suppurative or sarcoid granuloma. In the granuloma, the ferrule can be observed more evident with staining with periodic schist acid known as PAS or gomoric glaucot system. This could be one of the best diagnostic forms to realize that a person could have this disease, like in the following slide. When this is the forms that we could have a concrete diagnosis of the pathology with, for example, direct examination of sputum or exudated with 10% from potassium isotoxide. Allows to observe the ferrule primordially. You could have a cultive just for caution, that it's one of the most accurate forms of diagnosis from any dermatologic disease. You could have an histopathology study from schist acid and gomoric glaucot system that I just mentioned just moments ago. You could have serologic tests with IgM and IgG, realizing that a positive serological story for IgM indicates primary infections, while positive for IgG indicates dissemination. This is something very important to remember. And then you could have the skin test. The skin test could work with intradermal reaction with coccidiodidine, and if it's positive, it could appear symptoms after 4 or 20 days. And finally, we could have radiological study that could be just a common chest X-ray or CT.
For the diagnostic differential, we're going to do two different kinds. The pulmonary manifestation, which is going to be a differential pulmonary tuberculosis, histoplasmosis, and pericoccidioidomycosis. For the cutaneous manifestations, there's going to be cutaneous tuberculosis, mycetoma, sporotrichosis, chromoblastomycosis, and epitheliomas. For the coccidioidomycosis, it's directly diagnosed using potassium hydroxide and a tissue culture liquid culture. So it's important to note that from a histological point of view, in mucus polyps due to Rhinosporidium sebarii, it's possible to see large sporangia with numerous endospores inside. For the treatment, we're going to see fluconazole, 400 to 1,200 milligrams per day. This is specifically for the case of meningitis, itraconazole, ketoconazole, and amphotericin B deoxychelate or liposomal. And this is going to be specifically 0.25 to 0.75 milligrams per kilogram per day, every third day for 3 weeks. And this is in higher doses for patients with AIDS. It's reserved for severe forms of the systemic disease, and its treatment is usually followed up with results. It's also the primary treatment for pregnancies when there's systemic dissemination. Individuals with HIV might require antimycotics for life, and then there's surgical extraction of the pulmonary lesions and debridement of the lesions to remove the necrotic tissue. For epidemiology, we're going to see that it's observed in greater frequency in the desert regions of the Southeast United States, South America, Central America, and northern part of Mexico. It affects people of any age and sex, but there's a predominance for adulthood and males, although the disseminated disease is 5 times more likely in Mexicans, 25 times more likely in African Americans, and Filipinos is 175 times more likely. There isn't any direct transmission from person to person. And in the majority of cases in Mexico, it's diagnosed in kids of less than 5 years of age and adults older than 45 years of age. The incidence of extrapulmonary dissemination is 0.5 to 7%. For the risk factors, there are a few, which is going to be exposure in an endemic area. So whether you live there or you go visit, advanced age, immunosuppression, pregnancy, and diabetes. Thank you.
Good afternoon, Dr. Yuil and classmates. Today, my group and I have the pleasure to present our presentation about Cryptococcus infection. Okay, definition. Cryptococcosis, also known as Bossi-Borschke disease or European blastomycosis, it is acute, subacute, or chronic evolution. It can affect any viscera, muscle, bone, skin, and mucosa, but it has a particular affinity for the central nervous system. It usually occurs in people with immune disorders, especially disseminated hematogenous forms.
Pathogen. Cryptococcosis is a generally or pulmonary infection that is acquired through inhalation of soil contaminated with encapsulated with jets, Cryptococcus neoformans, or Cryptococcus gatsi. Epidemiology. Cryptococcosis is a worldwide spread infection. Epidemiological studies suggest that there are approximately 1 million cases in year in the world. Most cases of Cryptococcus occur in immunocompromised patients. TX or prolonged corticoids transplanted neoplants patients.
The pathophysiology. The cryptococcal infection is acquired by inhaling infectious particles through aerosols when the person is exposed to bird droppings. In most people with healthy immune systems, the infection is in a state of latency. However, in patients with HIV or in therapies that involve immunosuppression, the infection will become symptomatic. This may initially be located in the lungs, but it can migrate to the brain, producing meningoencephalitis that is a deadly form of infection, and other tissues attached to macrophage as a Trojan horse.
Clinical picture. Dermatologic spread can manifest with papular, nodular, or ulcerative lesions, sometimes mimicking those are acne, mold contagion, or basal cell carcinoma.
Diagnosis. The diagnosis is based on visualization of the fungal cell capsule in the cerebrospinal fluid mixed with Chinese ink. The cryptococcal cells in Chinese ink have a characteristic appearance because their capsule excludes ink particles. Another particularly useful test is the detection of cryptococcal antigen CRA in the cerebrospinal fluid and blood. The analysis is based on serological detection of cryptococcal polysaccharide, and it is sensitive and specific. The possibility of the CRA test constitute a presumptive data and great weight of cryptococcosis.
The treatment. 3 drugs are the basis of our treatment for cryptococcal infection: fluconazole, flucytosine, and amphotericin B. We must consider the stage of the infection. In case where the patient presents a localized pulmonary infection without extrapulmonary dissemination, or present an infection with extrapulmonary dissemination without presenting meningoencephalitis, the treatment to be followed will be fluconazole 200 or 400 milligrams per day for 6 months and amphotericin B 0.5 or 1 milligram per kilogram daily for 6 weeks. In the patient that has cryptococcal meningoencephalitis, the treatment will be fluconazole 400 milligrams a day for 10 weeks, amphotericin B 0.5 or 1 milligram per kilogram daily for 6 weeks. Also should be added flucytosine 100 milligrams per kilogram for 10 weeks. In HIV patients who present symptoms, The same treatment used for meningoencephalitis should be followed. Once the symptoms disappear, the treatment used for infection without extrapulmonary dissemination should be followed permanently or till the patient's immunity is restored.
Prognosis. Even with antifungal treatment, cryptococcosis is associated with high morbidity and high mortality rates. The most important factor for prognosis is the extent and duration of the underlying immune deficiency that predispose them to develop the disease. Thus, cryptococcosis is often curable with antifungal therapy in individuals with no apparent immune dysfunction, but in patients with severe immunosuppression, for example HIV, it is best to expect antifungal therapy to induce the remission. Thank you.
Thank you.
Hello everyone. Today my partner Gabriela Perez and I, Genesis Pertus, will give you a talk about paracoccidioidomycosis. So what is it? Paracoccidioidomycosis is a progressive mycosis, a chronic systemic granulomatous disease of the lungs, skin, mucous membrane, lymph nodes, and internal organs, caused by the dimorphic fungus Paracoccidioides brasiliensis. They develop in localized areas of South and Central America, most frequently in men between 20 and 50 years old, especially in coffee farmers who live in Colombia, Venezuela, and Brazil. 80% of cases in Brazil, followed by Venezuela and Colombia.
Etiology. It is assumed that the source of infection is the soil next to the freshwater course. The route of infection is through inhalation, and the incubation period, there is no incubation period because it can be from 1 month to several years.
Pathogeny. The lungs are the primary sites of infection by inhaling the fragments of the fungus. They are captured by the lung macrophages that spread to the organism by the reticuloendothelial system. Direct inoculation into skin or mucous membrane is not common, except for those who use swings to clean their teeth.
Symptoms. Most people who inhale the P. brasiliensis conidia develops an asymptomatic lung infection. Infection with clinical manifestation can become chronic and progress, but are not usually fatal. 3 patterns were identified. Mucocutaneous, infection that most frequently involve the face, especially the mucocutaneous junction and nose and mouth. This can usually be identified within pinpoint lesions spot at the granular base of the slowly expanding ulcers. Lymphatic, the cervical, supraclavicular, or axillary lymph node increase in size but are painless. Visceral, typical localized lesions cause hepatomegaly, splenomegaly, and abdominal adenomegaly. Sometimes cause abdominal pain. The main reason for a patient to visit the doctor is significantly weight loss in a short period of time, asthenia, and feeling tired of daily activities. Initial lesions have a ground glass appearance with some acinar lesions and some thickening of the axial gap, probably due to lymphatic spread. The infection can be mixed with all the 3 forms of it. Paracoccidioidomycosis can manifest as acute and subacute, but generally affect patients less than 30 years and manifest as disseminated disease affecting lymph nodes, liver, spleen, and bone marrow. An adult form caused by reactivation, which can cause chronic lung disease with pulmonary fibrosis, emphysema, and bullae. Diagnosis. Diagnosis can be made through culture, histopathology, or both. Samples can be obtained by scraping, puncturing, and biopsying. The culture confirms this, although the observation of large yeast, often no more than 15 micrometers with characteristic multiple budding, represents presumptive evidence and strongly suggests infection. Pathologically. In the histopathological section of a mold ulcer, the preserved with stratified flat epithelium is observed with spongiosis and pseudoepitheliomatous hyperplasia. On cytology examination, yeasts are best identified with silver impregnation Grocott Gomory stain. The fungi show offspring shoots connected by the stem cells, budding process giving rise to a classic appearance, already well described as a helm heel.
Treatment. So here we have the itraconazole. Azoles are very effective. Oral itraconazole is usually considered the drug of choice, especially since it is cheaper than the other azoles available in endemic areas. Intravenous amphotericin B can also clear the infection and is often used in very severe cases. Sulfamides, which are widely indicated in some countries due to their low cost, can inhibit the proliferation of paracoccidoides and reverse lesions, but they do not cure the disease and must be administered for up to 5 years. Thanks.
Thanks.
Cutaneous histoplasmosis. Etiology. The Histoplasma capsulatum is a dysformic fungus and is the cause of histoplasmosis. In Africa, the Histoplasma capsulatum varieri duboisi is also detected, which is characterized by larger chest and more frequently affects the skin and bones tissues. Macro and microconidia are the infection form.
Okay, epidemiology. Histoplasmosis can affect individuals of any age, but those in extreme age range can develop the infection because of their immune defenses. Rheumatologic manifestation can occur more in females. In Latin America, the histoplasmosis has increased because of the HIV infection. In Brazil, the histoplasmosis positivity is from 26 to 93.2%. In Panama and Venezuela is from 42.5 to 50%, and Mexico is considered the highest prevalence in systemic mycosis. Okay, clinical manifestation. Histoplasmosis have skin lesions that may be caused by immune reaction to an acute pulmonary infection or as a manifestation of disseminated histoplasmosis. There are 3 types of skin lesions: erythema nodosum, that is present as a painful red flake on the shins; erythema multiforme, that is a target or bullseye type of skin reaction; and the last one, pustules, papulas, nodules that may be throughout the body, and they might be caused by spreading fungus.
The direct test is not very useful because Histoplasma capsulatum yeast are very small and intracellular and usually goes unnoticed. The antigen and antibody test, it's positive in 90% of the patients with histoplasmosis after the 4 weeks after contact, and the presence of antibody may last for some years, so it's not possible to tell the difference between recent and past infections. The culture of tissue and fluid samples to detect this is usually the most specific but not the most sensitive method, because the culture success rate varies greatly according to clinical presentation and lab experience. The primary histoplasmosis cure itself 99% of time. The prognosis of chronic capillary histoplasmosis is determined by the loss of the lung parenchyma and lung function. Disseminated histoplasmosis associated with immunodeficiency has a poor prognosis.
The cutaneous histoplasmosis is may not require treatment, but itraconazole 100 mg bis has been used successfully for a period of 20 weeks. In more serious cases, it recommended the use of amphotericin B deoxycholate 0.7 milligrams per kilograms per day. In the case of pregnant women, the amphotericin B is the only recommended at indicated doses for 4 to 6 weeks. Thank you.